everyone, welcome back to the Leukopak Lady video series. This is the first episode of season 2. Thank you so much for joining me. I'm really excited to be back because I have a jam-packed season of great content planned out for you. This season I plan to cover topics such as Leukopak standardization, Leukopak economics, scaling up collections, off-site cryopreservation hubs, and I'll do a deep dive into contaminating factors that affect Leukopak quality. Also, I have 2 very exciting episodes that I've prepared for this season. How a Leukopak becomes an allogeneic therapy, which I'll release soon, and the donor experience, which will come out later this season. You won't want to miss those 2 episodes. But today I'm going to start out by talking about Leukopak standardization. This is one of those issues that everybody seems to be talking about, but not everybody is on the same page about. And it will be impossible to do this topic justice on my own. However, I want to highlight some issues and questions that I've seen come up in discussions about standardization. So one of the first points of disconnect in the field of cellular starting materials is defining standardization. Are we talking about standardizing the collection practices and protocols, or do we want a standardized collected product? And many will say that the collection practices are already pretty standardized. Collectors report following the instrument manual and receiving training from the instrument manufacturer. So how different could the collected products really be? And I agree that everybody is probably following a similar protocol, but the collected products vary widely across sites. And these differences go beyond just donor-to-donor variability. They're primarily found in the PBMC counts and the contaminating RBCs, granulocytes, and platelets in the bag. And I've heard reports from developers that get leukopaks with 20 billion cells or more in them, but half of those cells are granulocytes. Then, from another collection center, the leukopak arrives with only 8 billion cells, but it has 98% PBMCs and very few contaminating granulocytes. There are also frequent reports of differing numbers of RBCs between vendors, 2 or 3% hematocrit in the leukopak from one center versus 8 to 10% from another. So it seems like these centers can't possibly be following the same collection approaches or using the same instrument settings. And how can the same training result in something so very different? Collection centers all have different approaches about how long to keep the donor on the instrument, which is likely a significant source of variability. With some targeting a set volume of blood to process, others using a set time on the instrument, while a few use a collection calculator to help them collect to a target number of cells. And in my opinion, until the industry starts collecting to a target number of cells per leukopak, standardization can never be achieved. So this brings me to some donor factors that influence the ability to standardize. In addition to being different sizes and having different blood volumes, every donor has different white blood cell counts and different percentages of granulocytes and PBMCs in their blood. In order to standardize the collected product, these differences must be accounted for using a standardized collection approach. However, even when differences are accounted for, donors still have different percentages of T cells, B cells, NK cells, and monocytes in their blood. Therefore, it's not possible to standardize the proportion of each key immune cell population collected from a donor or a patient. However, it is possible to collect the right number of T cells or NK cells that a developer needs to begin their manufacturing run. So some key questions about standardization that I want to enter into the public discourse are, what do we want to be standardized in a leukopak? We can't have everything, but we can have some things. Is standardization achievable as it's being defined by the industry currently? How is it even being defined currently? And perhaps we can achieve protocol standardization and then define some key specifications that leukopak should meet. But what are those specifications and who defines them? Collection centers, cell therapy developers, regulatory agencies. And maybe we shouldn't attempt product standardization at all because each developer needs something different. And I don't have the answers to these questions on my own, but I am interested in being part of the discussion to answer them, given that I've worked in the field for quite a long time now. So come back for the next 2 episodes where I discuss specific factors and examples that may lead to variability in collections between centers and between the same donors. And unfortunately, these complicate the standardization discussion even further.